we're gonna pick up, we've got 5 joint play tests that we're gonna do at the foot and ankle. The first one is the distal tibiofibular translation test, okay? So joint play means that in between a joint, we're manipulating or mobilizing one of the 2 bones. So we're typically gonna stabilize one bone and then move the other one. So with this one, my movement bone is gonna be the fibula. So I'm gonna stabilize the tibia. My opposite hand is going to create an anterior posterior mobilization at the base of the fibula, okay, or over our lateral malleolus. I'm looking for increased motion. I'm looking for pain compared to the uninjured side, okay? In our pathologies, sprain of the distal tibiofibular syndesmosis, aka the syndesmotic membrane, and the anterior and posterior tibiofibular ligament, okay? If our patient complains about pain is going to be a better indicator for this test than laxity, okay? So just keep that in the back of your mind as you go through the special tests on your own. Okay, so I'm actually going to have you in a supine position. That way my bending is a little bit less, and I'm going to have you scoot forward. There we go. Actually, I'll do this side so Avery can see. Okay, so with this hand, I'm going to stabilize the tibia. With this hand, I'm grasping the lateral malleolus in between my thumb and my index finger, which is bent. So this is called a pincer grip, okay? So I'm gonna grab the base of the fibula in a pincer grip, and I'm just moving anterior to posterior, anterior to posterior, posterior to anterior. So I'm just kind of going back and forth. Any pain with that, Kristen?
No.
And again, I would always test on my uninjured side first and then my injured side, so I have something to compare it to. This is a picture showing with the skeleton, so if you're having a hard time visualizing, this is embedded into your PowerPoint lecture, okay? The next one is assessing for movement at the medial subtalar joint. So we're gonna do an anterior, or a medial to lateral glide of the talus on the ankle mortise, or on the tibia and the fibula, okay? So I'm gonna have my patient lay on her injured side. You can pick which one's your injured side. All right, we'll do that one first. Okay, so when we do the lateral glide, I'm gonna have my patient on her injured side, and then I'm gonna grasp her talus in one hand. So if you wanna come in close, Avery, and then I'll actually grab the model so we can grab the model, so I can show you, okay? One hand is gonna stabilize the talus in the mortise. The opposite hand is gonna grasp the calcaneus, okay? I'm gonna move the talus from medial to lateral, okay? So I'm gonna grasp right at the, talus. I'm gonna grasp this hand at the calcaneus, and I'm just gonna create this lateral gliding movement. Okay, any pain with that? I like doing this one on a table because it gives you a little bit of cushion, so it's not as uncomfortable in the patient's ankle. But your opposite hand, or your stabilizing hand, is also going to kind of create that cushioning movement, or that cushion for the foot. So as we look at the model, same thing, you'll see patients in a sideline position. Okay, actually it should be this way. Patients in a sideline position. I'm grasping the talus here, right? And then I'm moving laterally. And because of the fibula, the talus catches, right, on the distal aspect of the fibula. Okay, so I'm seeing if that creates any additional pain for my patient, or increased pain for my patient. Okay, the next 2 glides you will learn next semester as a treatment technique for your patients who have immobile subtalar joints. So this happens oftentimes after an ankle has been injured. Okay, so you're gonna start with your patient in a supine position with the foot in slight plantar flexion. So you can see the angle of the ankle is a little bit in plantar flexion, okay? So I'm gonna grasp right above the talocrural joint, or the ankle mortise, to stabilize. Using the web space of my hand, I'm gonna essentially palpate right over the talar head. And I usually will wrap my fingers around the posterior aspect of the tibia and the fibula so that I can really stabilize that anterior to posterior joint mobility, okay? And I'm looking for hypomobility and pain. Any pain with this?
Nope.
Okay. In your next interventions class, you guys will use this as a treatment technique. And this is one of my favorite ankle treatment techniques for patients who are lacking in dorsiflexion. So if you have hypomobility at the talus, in the subtalar joint, you're typically gonna see that play out as a lack of dorsiflexion. Okay. For the opposite, for our posterior to anterior, our patient's going to be in a prone position. Okay. Same thing. You're stabilizing that anterior portion of the tibia and the fibula. I'm grasping right over the Achilles tendon with my web space, and I'm providing this lovely posterior to anterior force. So a little movement there. So you guys may think or recognize this looks a little bit like the anterior drawer, which is true. I'm providing that same movement, just now from a prone position rather than a long seated position. Okay, so if my patient has any lateral ligamentous laxity or anterior deltoid laxity, you may get a little bit of movement, which you can feel on Kristen. There's a little bit of a click with the anterior movement. If you've ever had an ankle sprain before, this is likely to create some sort of movement in that subtalar joint. Thank you.